So, quick introduction of who I am. Um, my family lives with bleeding disorders. We have two kinds of major bleeding disorders in our family. One many of you have probably heard of called hemophilia. We actually adopted a little boy from China who has hemophilia A. He's now 16, so he's been with us for about 6 years. And we have three biological children, and my husband all live with another chronic bleeding disorder called von Willebrand disease. And that is 1% of the population. So about 10% of that number know they have it. The other 90% are undiagnosed. So if you've had histories in your family where you've learned that like the woman died in childbirth or they bled to death from a tooth extraction or whatever, those are probably people that had VWD that went undiagnosed because it's a newer disease, but a much more common disease. And as I said before, I'm the executive director of Pacific Northwest Bleeding Disorders, and I serve as the Oregon All Copays Count coordinator. So let's talk a little bit about healthcare and the cost of healthcare. We all know that is extremely expensive. Um, I just took these statistics from the CMS website, and it says that it's going to grow in the next several years to 19, like 20% of our GDP is going to be healthcare. That's a huge number because the US GDP is huge. So when you think about that number, it's pretty significant. Here are the facts. What are payers? Payers are insurance providers. They're the insurers and PBMs. They're the ones who pay those bills. And some facts about who is included in that. The high cost claimants are defined as someone over $50,000 annually. Just to give you an idea, a person with hemophilia is around $500,000 to $1 million a year. A person with von Willebrand's disease is between $50,000 and $150,000 a year. So they're 50,000 to 150,000. So we all fit in that category. The average annual individual cost is 122,000, 29.3% or times higher than the average person. So 30% higher than the average person if you don't have a chronic disease. And it represents 1.2% of the population, but 35% of the spending. So what are payers looking for? Let's go back historically. So let's talk about first manufacturer copay assistance. Most specialty drugs have copay assistance. So I'm not talking about the coupons. That is not copay assistance. And I can explain that a little bit later. But one of our biggest challenges is that many members of the legislature think that coupons are the same as copay assistance. They are absolutely not. And all bleeding disorder medications have copay assistance, and those range from $12,000 to $18,000 per person. This year, the ACA out-of-pocket limits are $9,450 for an individual and $18,900 for a family. I don't know if any of you have what they call high deductible or high out-of-pocket plans. My plan is $5,000 out of pocket. So that's still considered high deductible. Thankfully, it's only 5,000 because I keep hearing people that have much, much higher. We can meet that with our copay assistance because you can see that we have 12,000 to 18,000 per patient, and I have 5 patients in my family. So we could easily meet that out of pocket with the help of manufacturer copay assistance. Here's what the payers are looking at. We know that copay cards help patients. They improve access, affordability, and compliance. So if you have a bleeding disorder and you can't afford your medicine, you then don't take your medicine, you then have bleeds in your joint, you destroy your joint, and you cost more as you get older. So some plans believe that they increase costs by allowing them to meet their out-of-pocket max more quickly, and payers have to pick up the plan cost for the remainder of the year, or they incentivize patients to stay on non-preferred drugs. Many of you are associated with chronic disease. You all know that these diseases do not have over-the-counter drugs. They're all specialty drugs, right? Very, very few. I think I only know of a couple that even have a generic. So there isn't really an option for a non-preferred drug. The copay assistance is not intended to keep a person on a non-preferred drug. It's to keep them compliant and have access to their meds. So, in response to these issues, they decided in 2017, and two new programs came about by PBMs. And I think everybody knows what a PBM is, but a pharmacy benefit manager. They're copay accumulator adjuster programs, or CAP. Many of you may have heard of that, or CMAP, copay maximizer allowance or accumulator program, whichever you want to call it. So they were primarily rolled out by self-funded health plans, and self-funded health plans are usually large employer plans and they're all managed at a federal level. So that'll come in a little bit later. They're offered free of charge by the PBM to the insurers. That would mean, and that's why you've seen insurance companies now go specifically with a contract with a certain specialty pharmacy. So I can only speak to bleeding disorders, but in the case of bleeding disorders, there are three large specialty pharmacies that are contracted with, and across the board, pretty much every single plan has been contracted with one of those three large PBMs, and therefore you have to get your meds through them. However, we have an alternative that is cheaper for insurers, but they can't make exclusive contracts with them. It's a 340B program that's offered through just about every hemophilia treatment center nationwide, and they get the best negotiated rate for all bleeding disorder drugs. And so therefore, by making an exclusive contract with PBM, they're not getting the best price. So that's what we've been working hard on, is trying to get insurers to understand and employers to understand that you can have the option to go with the hemophilia treatment center as a 340B option instead. I'm happy to answer any questions. I didn't say that at the beginning. So please stop me if I'm using phrases or talking about things that are not clear. So copay accumulator adjuster programs, they require no plan changes, and there was a very high level of interest by insurers and employers when they first came out. In fact, as they learned of it, they implemented it almost as soon as they possibly could in a lot of cases. And we saw that by 2020, so just 3 years into it, nearly every plan that could possibly have it accepted copay accumulators. So what then happened was they needed another way to sort of hide it, like make it look a little different so it didn't look like an accumulator. And that was the maximizer, which is what my family was subjected to in 2020. And what happens there is it does require a plan change. It is harder to manage. And there was a lower level of interest immediately, but within a few years that it has now taken on. And we're seeing that there are sneaky ways for them to get the maximizer into plans so that people don't even realize a maximizer is there, even in states that have passed regulation. So let's talk about some of the facts. Nationwide, a lot of my stuff comes from the AIDS Institute. So if you're not already familiar with them and their materials, you should look them up. They every year put out a report that talks about where plans stand. They give a lot of statistics about how many plans nationwide, and they look at each state individually and give each state a grade. And in 2023, Oregon got a D rating, and we've gotten a D rating for multiple years prior to that as well, because we have a large percentage of our plans on our marketplace that have copay accumulators or maximizers in them. So as you can see by that first statement, 2/3 of all individual health plans currently in the marketplace have copay accumulators, but there's a big variation from state to state. Again, you should try to find that report. It usually comes out in March of each year, March, maybe April. So there'll be another one in 2024 from the AIDS Institute. Here's where I want to talk about coupons versus copay assistance. And this is where we could really use your help. As you talk to legislators, even Senator Gelser, one of the sponsors of the bill in the past, calls them a coupon. They are not the same. Coupons reduce the cost of a drug, usually over-the-counter drugs. An example is, I take a medication for allergies, right? I can get a manufacturer coupon to help reduce the cost of that medication, the allergy medication, and it's provided directly from the pharmaceutical company. However, a specialty drug is not bought typically through your local pharmacy. It is usually bought through a specialty pharmacy. So copay assistance provided by the manufacturers actually is money. It's financial assistance that pays for your costs of your deductibles. So there's a very big difference. Manufacturer coupons are to help reduce the cost. Manufacturer copay assistance is actually financial assistance to pay for the med. So we need to stop using coupons and copay assistance as interchangeable. I think that's a big misunderstanding because one of the things insurers will say is they will say, oh, California and Massachusetts outlawed coupons. We're not talking about coupons. That's not what we're referring to. So if you could help spread that word, that would be beneficial. And then when you're trying to understand a copay accumulator, it's important to know phrases deductible and out-of-pocket maximum. I'm sure most of you already know that, but keep that in mind when you're talking about it. That's also something that people try to get confused. A lot of insurers try to make it sound more confusing than it is. Insurers will take the copay assistance card as payment, but reset the out-of-pocket max back to zero, meaning zero paid by the patient. That's where the accumulator, I don't know why we call it that, but that's where that phrase accumulator comes in. They reset your accumulator. This occurs month after month until it is completely drained. And then you have to pay your full deductible until you're out of pocket max until that is met for the year. So that's what an accumulator is. Maximizers are slightly different. They look a little bit different in plans. They're actually more difficult to regulate unless it's specifically said so in the laws. It's similar, but they don't count towards your out-of-pocket max. Basically, a maximizer spreads the assistance throughout the entire year. If the copay assistance program, for example, has $18,000 available, the patient copay for the medication is $18,000 divided by 12, which equals $1,500 a month. So that becomes your monthly deductible. It happened in my husband's company, and that's what we were subjected to in 2020. So it spreads it out throughout the entire year, but you will still have to pay for the other, if it doesn't count towards your out-of-pocket max, you will still have to pay for the other services that you then incur until you hit your out-of-pocket max. So what a lot of insurance companies are trying to do is they're trying to propose language, and they've already tried this in Oregon, where sure, we'll ban the copay accumulator, and we'll let it count towards your out-of-pocket max. But if any money is paid whatsoever by a third-party program, patient assistance, whatever, manufacturer, then they get to take all of it. So, for example, if they pay even $1 from a manufacturer copay card, they get to take all $18,000, is what the language says that has been submitted by the insurers in the state of Oregon. So it's their way of still draining all of the manufacturer copay assistance, despite the fact that that's not even what's owed to them. And I should clarify here that state after state has done all kinds of reviews. Companies have done all kinds of reviews. There are 19 states who have banned copay accumulators and maximizers, the District of Columbia and Puerto Rico. Those have all been banned. And they have found that there's been no significant increase in insurance rates across the board in those 19 states. Zero, pretty much negligible rates. If any, it's below what has been the normal trend of insurance increases year to year. So the argument that maximizers and accumulators will increase the cost of insurance just doesn't hold true. because many of these have been banned since 2019, 2020 in other states, and they're finding that there has been no increase in insurance because of them being banned in those states. So that argument is not even worth it. And it's definitely something that we can also use as a way to combat that. I do want to go back one slide and talk a little bit more about accumulators, just to give you a clear picture. And this is a great story that you can use with any of your representatives. Imagine that you're a college student and you know that your tuitions, I'll just use my daughter that's a sophomore in Colorado State. She has a tuition bill of, let's say, $34,000 for the year. She goes out and she gets $20,000 in scholarships and gets those paid to the school, and then she's only responsible for $14,000. So it would be like the school, Colorado State, saying, you know what? Because you didn't actually pay the $20,000 out of your pocket, we're going to take it, but we're not going to count it towards your whole tuition bill. So we're going to take the money and you still owe us $34,000. That is the best example I can give you as to how an accumulator works. They will take your money because you have access to it, they will take it, but they will not let you count it because it didn't come from you specifically. So if it comes from a third party nonprofit, if it comes from a copay assistance program from a manufacturer, whatever, they won't count it. So what happened was a lot of companies said, okay, well, we're just going to make it look differently when we pay for that. Like we're going to give a credit card from one of the major manufacturers' copay assistance plan. They went around that even, and insurers are forcing anybody, pharmacies, to tell them what was used to pay for it. So a good example is our Hemostasis and Thrombosis Center has what I refer to as a 340B program. And they said they've now been asked, how was this paid for? So, for example, Blue Cross Blue Shield would say, oh, I can see that they've met their out-of-pocket max. How was it paid for? Did the patient pay for it, or did you bill manufacturer copay assistance? So they now have to answer that question to the insurers that they're providing service through. So they're literally trying every way to figure out if somebody paid for it themselves. All right, before I go on, I want to make sure, does anyone have any questions? I just keep talking and talking. Okay. So here's another example of an accumulator. So a patient has a $1,000 deductible. They have $500 in copay assistance. With no accumulator, it counts to their out-of-pocket max and they reach their deductible. The rest of their plan year is paid for by their insurance provider. An accumulator program does not count towards their deductible. $1,000 equals or minus 0 equals still 1,000. So that's the accumulator I was talking about. I like to use the example of the college student. It's very applicable. A lot of the representatives understand that very clearly. Okay, so here's an example of a maximizer. I'm not sure if you all can move your pictures out of the way so you can see it. This is based on the 2023 out-of-pocket maximum. So you can see that the annual out-of-pocket maximum there was $8,500. It's now $9,400, as I told you. So with the copay assistance, without an accumulator, you can see in scenario 1, the copay assistance pays $1,680. The remaining deductible is $2,920. The patient pays 0. The next month, they get the copay assistance. The remaining deductible is paid, so they don't really pay the $1,680, right? They can just pay the amount that's due until they meet their out-of-pocket max. That's what the red outline is in the end. This came directly from the AIDS Institute, and it does a pretty good job of showing you where people can meet their out-of-pocket max without an accumulator. And then with an accumulator, you can see that the patient still in May, in our case, it would be much earlier, but in May, they start to pay their out-of-pocket costs because their plan stopped paying because they no longer could get it from the copay assistance. So I hope this clarifies a little bit more what a maximizer does as well. It sort of spreads it out over the year, and when you hit the end of that, then that's when you have to pay. So where are we at the state and local level? I mean, state and federal level. So Oregon, we hope a third time's a charm. We're going to be introducing legislation again during this short session. It's sponsored by Representative Levy, Senator Gelser-Bluen, and Senator Knope. The reason Levy is taking it over is because originally it was supposed to be Representative Nose, and he was going to put it in his big health omnibus bill. He has a healthcare omnibus bill that's coming out from the committee. He is the chair of the Behavioral Health and Healthcare Committee. He met with Representative Levy. She talked about a constituent really being concerned about the copay accumulator being applied to their plan. So she's very interested in this issue. He turned it over to her. We do have legislative, well, we have an LC. Basically, it's the draft that will be dropped, and then we'll get a bill number. So we've seen that. It is available. If any of you are interested, I can forward it to you, or Lauren can. She has it as well. So it's starting off in the Behavioral Health and Healthcare Committee. We expect to have a hearing. Representative Nose has promised us a hearing early on in the session, in the session. And so probably the week of February 5th, assuming that we don't have any issues, we are going to work that committee very hard to make sure that we have all the votes. So assuming we don't have any issues, it will move on to the Senate on February, onto the House floor. It'll hopefully pass the House floor with a really high number. Last time it got passed through the Senate, it was unanimous. So we're hoping the same will happen in the House this time. It actually hasn't ever gotten to the House floor for a vote. So fingers crossed that it does this time. And so assuming that it gets over to the Senate, that would be then the second week or end of the second week into the third week that we would be testifying there. And then in that Senate Healthcare Committee, Senator Patterson has told us that she will not oppose it. She will put it up for a vote. She's promised us that in the past and has not put it up for a vote. So we're hoping that she follows through with her promise this year and that we will get a vote in the Senate Healthcare Committee. Insurers have pushed for language to allow maximizers. However, Representative Levy has already promised that she would put in an amendment to remove that language. We do have an appointment with her next week. She's great about listening to patient perspective. So we're hoping that we really do have her ear and she's able to get that work done for us. One of the biggest things ever is that this is not intended to be a fight between pharma and insurers. If we don't get that language out of there, pharma is going to kill it. Because pharma is not going to put up with taking care of the maximizer. The issue with us is that this is a patient issue. If there are issues with pharma, like high cost of drugs, insurers, all that kind of stuff, if they want to have that fight, that should not be part of this bill. If they want to put any language in that would cause that sort of fight, they should put it in the omnibus bill that NOS is working on. So as any of you meet with legislators, this is not something that we want to be a fight between pharma and insurers. This is purely a consumer bill, and it should stay clean and clear that it's a consumer bill. So the cleaner we keep it, the better chance we have. However, working against us is that much of the session is going to work on the Measure 110. You've probably already seen Republicans have already put in a major reform bill. I've heard that it's going to be dead in the water when it gets there, but I don't know what's going to happen with that. The other priority is wildfire issues. So they're going to put some protections in. If you're working in Washington at all, the good thing is they passed this copay accumulators and maximizer ban in 2022. I wish we would have been able to be as successful in 2023, but we weren't. And then finally, there are two pieces of legislation working through the House and Senate at the federal level. 5 of 6 Oregon representatives have signed on as sponsors. Val Hoyle has not. All right, so I've been talking for about 25 minutes. I can stop talking and happy to answer any questions. That was a lot of acronyms and phrases and a lot of stuff thrown at you. I'm sure all of you have seen them before, but I'm happy to answer any questions you might have.
No, the presentation was really, really good. I think so basically it's you're paying a certain amount for your prescription and you're getting some money off. Because I'm just trying to put it on to perspective because I do feel like at a certain point my medications were going against my deductible, whereas they
Right.
don't so much anymore.
Correct. So they've done a couple of different schemes other than copay accumulators. What they've done is they've moved them to pharmacy benefits instead of medical benefits. So a specialty drug used to be medical benefit almost all the time across the board. We've seen in the last 6 or 7 years, they've moved them to pharmacy benefits and then they put them on tiers. And if you meet a certain tier, then you get a portion of it paid for. They've also gone to percentages. So if you, instead of being a $30 out-of-pocket cost that you knew about, it's a percentage of the cost of the med. And you don't know what that percentage is going to be from year to year. And it can be negotiated and changed every 3 months or 6 months, whenever pharmacy has a new agreement with the manufacturer. So if you're 20%, but for example, we just ordered 10 doses for my daughter who's going over to England for study abroad. Her doses are about $7,000 a dose. That's $70,000. So if you had to pay 20% of 70,000, you couldn't do it. Like,
Right.
so that's what's started to happen. So there are other schemes that they've used to make it so that you pay more of it. So they're shifting more of the cost to the consumer and less of the cost of insurance.
And it's all just going back and forth between, yeah, yeah.
Mhm.
Because yeah, it was like all of a sudden I'm like, because I felt like my prescriptions were covering most of my deductible by at least the middle of the year. But now it's
Right,
like I just feel like I'm always in this hole. And then
right.
uh, yeah,
But you need to see if you have an accumulator or a maximizer in your plan. They don't tell you anymore. They've changed the wording. They call it like co-share or co insurance or whatever. They call it all kinds of crazy things. So you really don't know what it is. It's not going to say this is a copay accumulator. It's going to say, co-insurance or sharing the costs or whatever, right? And it's not really sharing. Basically, they're saying we're going to take more than what you actually owe us. For example, our family owes 5,000 out of pocket. Beginning of every year, we place the order the first week of January, we meet our out-of-pocket max. When when they found out that we had 120,000 available on manufacturer copays, that's when we got hit by a copay accumulator and they took 120,000, but they were only owed 5. So they find ways to take more than what they're actually owed.
oh. And then you just wonder, like, on top of all of it, like for us to trying to be negotiate about prices in general, it's like that's just the tip of the iceberg. Like,
Exactly. And
ah,
then the manufacturer prices go up because you've now drained their patient assistance and they need to come up with a way to fund that patient assistance. The only way they're going to do it is increase their prices. So we're just causing more high costs of drugs by allowing insurers to take all the money that's not even theirs to take in the first place.
right. It's just like a car payment where you're like, okay, yeah, it'll be $200 a month, but then your insurance is like like
Right.
20% or something. Yeah.
Right.
Oh,
So
okay.
people need to look at their plan year after year. If you're like my husband's company always says, oh, we didn't really change anything in the plan, just get signed up, right? No, they do make changes. Like they've negotiated contracts specifically with a certain specialty pharmacy, or they've now gone to a percentage versus an actual dollar copay. I mean, those are the things that they change, but they tell you it's just about the same. There are very few changes in it. And then people don't read them. And then they're hit by these accumulators or maximizers partway through the year. And they're like, wait a second, what? I didn't know. You told us that it didn't change.
I know. And then somewhere down the line, it was like I was responsible for my individual copay, but now all of a sudden we have to reach the family one too,
Right.
which is like, come on.
Right.
I'm the sick one. Why do like I don't know, it's just weird, but
No,
ugh.
it's frustrating.
Thank you for that though. This yeah, is very helpful.
If you
Thank
have
you,
any
Madonna. That
questions,
was awesome.
if you have any questions come in, or if, especially after they've seen the recording, please feel free to send them my way. I'm happy to answer any of those. I live this every day with my own family, but also through our organization. So happy
Great.
to answer anything.
I was curious about though the 340B sort of intersection with 340B, Madonna. I know that some states have started to, like the state has started to capture 340B dollars and then is redistributing that to federally qualified health centers and community health
Mhm.
clinics. I don't know if that's something that has been impacted. When you mentioned there are opportunities for, or there should be opportunities for insurers to contract with what I presume is sort of FQHC networks, accessing the
Sure.
340B
Yep.
price. If that move, and I'm hearing in Washington there might be a move to do something similar, maybe
Yep.
next year. So it's a little bit of just like kind of trying to lead the issue a little bit, but how that change, how that structural shift, if the state were capturing 340B dollars, how that would interact with any of the policies that you're talking about here, or
Sure.
if that's come up in your work.
Sure. So interestingly, if you're a dish hospital, which is the designated, I don't even remember what dish stands for. I just know it's a dish hospital. If you're a dish hospital, you're the next tier of 340B. So the reason that 340B, it came about in the 70s, right after hemophilia treatment centers were designated. And initially, 340B was intended specifically for not just hemophilia, but cases like that where it was difficult to get medication. So there's been two tiers of 340B. The initial was early on. The second round came in the 90s, I think it was. So the dish hospitals are the ones who are no longer required or don't have the same requirements as the initial 340B recipients. So the initial 340B recipients are required to put it back into the community. For example, in Oregon, it's Oregon Health and Science University that is the designated 340B for hemophilia and bleeding disorder drugs. They are required by federal law to put that money back into the patient. So they therefore pay 100% of our camp for kids that live with bleeding disorders. So they pay, and our organization, they give us well over $100,000 every year in support. They also are able to provide like education specialists so that they can work with schools and right. So they already follow that law. They have to follow it to the letter of the law. They're audited constantly. And OHSC was one of the 8 regional centers that also get that funding. So then they have to send that money out to other entities. So it's the dish hospitals that are doing things a little bit differently and not necessarily following the true letter of the law. The dish hospitals are the ones who are capturing that 340B, even if it comes through hemophilia, and they're taking the money and not allowing the HTC programs, the hemostasis and thrombosis centers, to use it back for patient care or patient support. So that's why the 340B reform is happening at the federal level, because the dish hospitals are not reporting at the same level that the initial grantees were reporting at. So the initial grantees still have those basic requirements and they get audited constantly. The dish hospitals don't have those same requirements and they're not audited at the same level. So that's the reason why 340B reform is such a big deal. And we don't like the 340B reform. It's coming from manufacturers because manufacturers don't want to be held to the requirement that they have to, keep a rate. They want higher rates. They want to be able to get higher pay for the products that they're selling through 340B. So it's really coming from manufacturers. So I'm not a friend of insurers or manufacturers. If it came across in that presentation that I'm a friend of one or the other, I'm really not, because it's the manufacturers that are trying to reform 340B. And for us, that would be terrible. We don't need 340B reformed. We already feel like it's doing the right thing. So I don't know if that was more than you wanted to know about 340B, but
No, that's cool. Yeah, no, and I heard there's sort of like a new coalition, I guess the National Community Health Association. I don't know what the acronym is, but whatever. It's the national group that does all the lobbying work for the community health
yeah.
network, has sort of refreshed the 340B reform effort. I think it's
Well, because they want to do what they they want to do whatever they want with the money. They don't want to have to follow the guidelines. They want to use it to pay overhead. They want to use it to pay all these other things that it's not intended for. It's literally intended for patient care, patient support.
Right. That's interesting. Yeah. No, and I wonder, like, even right, your point about like the dish hospitals have a lower level of accountability than the community health systems do, or the federally qualified systems do. It doesn't make sense that you wouldn't have everybody sort of having to adhere to the same amount of transparency, accountability on how 340B dollars are spent. Because then you can really say, okay, like, here's the one-to-one relationship between dollars being spent and patients being helped. That's strange to me that there would be different requirement entities. I don't know. That's not really a question.
No, it's actually just a different tier of hospitals were introduced. They were allowed to enter the 340B program in the 90s, like 20 years after they had already implemented a 340B programming. And so it just, when it was passed, they were just given a different level of accountability, which doesn't make sense. If you're a 340B, you should have the same. I feel like the letter of the law should have been followed from the initial. Like, why are there two tiers of reporting? Why is there, anyway? So we work with our HTC, we call it HTC, it's Hemostasis and Thrombosis Center at OHSU. We work with them very closely. I've also traveled to Washington and lobbied with them as well for that same 340B, or sort of against 340B reform.
That was a really comprehensive presentation. Thank you. I learned a lot. I appreciate it.
Oh, good.
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 Yeah, I did too, Madonna. Thank you.